All right, we're going to move on to the next section, and I don't feel like these two ladies really need an introduction, but I am honored to introduce them. So we have Kristin Smith. She's the patient navigator at Northwestern. She was implemental, I think, in how Oncofertility has grown, as well as implemental in some legislation in Illinois. And then we have Joyce Reinecke for the Alliance for Fertility Preservation. She works tirelessly, working with multiple teams across the country to try to improve legislation and access to care. So I'm going to turn it over to you guys, and this is how you advance your slides.
We're going to stand and share the microphone because that's kind of how we roll. So thank you so much for having us. We could probably talk for, well, like all day. So we will try and get this done in 20 minutes so that we've got time for questions.
And I just want to thank Kyle. Where's Kyle? Oh, he left.
Thanks, Kyle.
Thank you for having us here and having interest in this subject.
Just saying thanks. Okay? To you.
Okay. I just wanted to start out by pointing out some of the complexity that we're up against in terms of getting this covered. It's obviously not a single system of insurance here in the United States, so we're constantly looking at gaps and who we can cover, and so we just want you to know, obviously, changing state law to get this coverage is not a silver bullet, and there are going to be groups that are left out because of this system that we have.
And I think I've learned so much in this process, but one thing I really learned was this whole idea of employer-based insurance, which so many of us have and so many people in the US have, but that there are self-funded policies and then fully funded policies. And the self-funded policies do not have to follow these state mandates that go into effect. So even when you have this coverage in your state, you're still going to have a whole swath of patients who have no idea that their plans are self-funded, and you've got to kind of work through all of these issues, so you definitely need the right people in place who can ask those questions. And I think we also want to point out, and this is something you guys all know, but well over 50% of the United States population does not have any coverage. It's a big goose egg in terms of coverage for infertility services. And we all know that infertility service and fertility preservation services are crazy expensive.
So I just want to point out that we have seen a positive trend in the last few years of employer-based, employers adding this coverage to their benefits voluntarily. So sometimes I forget that that's out there and that's an option and a way to gain coverage. But that also tends to complicate the situation.
And I can tell you, like at Northwestern, for example, if I have a patient in the cancer center who's got a Blue Cross Blue Shield plan, is seeing our oncologist there, everything's going great, they come over to see us, and then I start doing some digging into their insurance, and I realize, oh, they actually have Progeny as their fertility benefit manager. Well, we're not partnered with Progeny. So I've already seen that patient, sometimes drawn labs, done a whole consult, and then I have to find a Progeny provider that I can urgently refer this patient to. Same goes for Fertility. So it adds like one additional layer of complexity to this entire insurance situation.
So we just thought we would start also by taking a step back and looking at infertility and how that's defined and how that is defined in the law of coverage. And so I think this has been pointed out before, but there is a trend toward moving toward labeling infertility as a disease, and so the World Health Organization has done that. The AMA has done that and endorsed that definition. And I think that is an important context for us to think about when we're talking about fertility preservation and offsetting basically another disease down the road. So I think that that's helpful to our discussions. And the legal definition actually has been evolving even further in some of the new bills that we have been working in coalition to put forward. So I'll give you an example of that. This is language that was developed by Resolve, which is it's an infertility organization, the National Infertility Organization. And we've been working with them on bills that are both IVF coverage and fertility preservation coverage. And they've really introduced this new definition. And you can see that it's getting away from some of these bills that had very heteronormative definitions of infertility and expanding what would be covered and who would be covered. So we think that's an important change and a positive change.
And I think you guys all know this. We're all here for the same reasons, mostly. But when we're talking about fertility preservation in terms of legislation, we are talking about iatrogenic infertility. We are not necessarily talking about planned egg freezing or kind of what was formerly called social egg freezing. So just want to make sure that we make that distinction, that this is really about medical kind of fertility preservation. And this is one of my favorite slides because I think it gets a little bit at the crux of the situation, right? You've got these people who, think about infertility and see infertility as being this elective thing that you can jump into. But if you talk to them about cancer, they're like, oh, cancer, it's bad. Yes, they're both bad. But I think you can get a little bit further sometimes, especially with some idiot legislators, when you talk about sort of the medical necessity as it relates to a cancer diagnosis versus, coming through with sort of this infertility when they view that as like some crazy elective procedure that people do.
So, and just to kind of summarize it again, you guys probably are fully aware of this, but just in terms of who needs fertility preservation, mostly when we're talking about this, we're talking about cancer patients. And so we use this figure of about 160,000 people diagnosed each year, but that's 0 through 45. So it subsumes and includes the AYA population, which you'll often see quoted, and that's a smaller number. Obviously, there are many factors that go into who's going to actually need preservation, as we've been talking about, and how difficult it is to assess individual risk. And I think it's important also, what we have been hearing in our organization lately is we've had outreach from other patient populations who are seeking fertility preservation, such as the transgender population and sickle cell. We've had a lot of interest and inquiries about that as those patients are being moved to more curative therapies like bone marrow transplants. So we are always trying to be cognizant of these populations and making sure anything we put forward is as inclusive as possible. So in terms of the costs, and you all are very well aware of these, but this is really the challenge, right? The challenge is out of pocket for someone in this emergency situation. This can be prohibitive. And so we think that removing that barrier, removing that prohibition to treatment is really the goal of getting coverage in place so that they can have access to services immediately.
And I think something to think about with this too is that we're talking about a cycle of egg freezing, right? And as we just talked about, sometimes you need more than one cycle to get the job done. Sometimes you need, what we've heard is actually 3 is kind of the average that's needed. So we're not talking, $10,000, $15,000, we're talking maybe $60,000 for some of these people to actually have a successful live birth.
So I think we've spent a lot of time, thinking about fertility preservation and whether it's a subset of infertility. And so up front, when we were introducing the topic, obviously we're talking about some of the cons of being associated that way and with that coverage. And I think increasingly what we are really trying to argue for is kind of this other arrow of really adding fertility preservation on as like an oncologic service and looking at it that way through that lens. So to date, this all really began, I have to say, I think one year when I was here for a similar talk, we started and showed the map and it was blank. And then we kind of time-lapsed in a couple of states, and that was very exciting. It was like 4 or 5. But we are at the point now where just this week, I think it was Tuesday? Oh, the 2nd? The governor of Maine signed a new IVF and fertility preservation bill. So that coverage will take effect in 2024, unfortunately, but it's been done. So there are currently 12 states that have enacted some kind of fertility preservation coverage. And again, because the state can only dictate to the groups that they regulate, it's not going to capture everyone within the state, but at least we're making some inroads.
And I think if you look at that map and your state is white, what can you do about it, right? So I don't know if you can see really well, but there's like kind of a yellowy color where those states have had legislation, they've got something moving. So if you're in one of those states, what can you do to help move that forward? Let us know. Really, let Joyce know.
And I know many of you out there, are doing this and are organizing, and so we're happy to help with that in any way possible, since it's a big country and got a lot still left to do. I always try to include this slide. This is what I've come to kind of refer to as the North Star, and this is a model. This is the Women's Health and Cancer Rights Act, and this actually affected federal law. And it basically said to any insurer that was covering mastectomy that they had to cover reconstruction. And so I think it's a great model for us, and it lays out sort of a framework. The country, up until that point, different states had passed different coverages, and I think someone referenced it yesterday, it's just unfair, and I think that's how it came to be seen, that just because you were across state lines, you wouldn't have access to reconstruction, that was simply unfair. And so I think at the point that this was passed, there were 19 states that had passed state laws. So we're getting closer and closer, hopefully, to that tipping point where we can really make the federal argument. This is just to give you kind of an overview of what we've sort of identified as what we consider our model legislation, and we have these documents and can get them to anyone who's interested in kind of socializing this within your own state or with your own legislators. But it's just we want to try to get the broadest scope possible and the most flexibility within the fertility preservation coverage, so that it would allow for multiple cycles, no age limit. So there are sort of guiding principles that we have that drove this language, and so we're happy to discuss that as well. Do you want to do that? Okay, so this is just essentially what you saw in the map, but in a table. And the only reason I include this, it's really busy, and obviously no one can really read it from where you're sitting, but it's that it just keeps getting longer and longer, and we're sort of tapping out on the space there. But so Maine was just added, and we're not certain about how many people will be covered yet. They did draft it in such a way that it will go to all insurers, but there is a caveat there in the language that gives the state an out if they are found to be in violation of the ACA, which is a whole other topic. And unfortunately, because they're restructuring their state insurance exchange for individual and small group, the small group market, they have put off implementation until after that's done. So that will happen next year, and then this coverage should go into effect in the beginning of 2024. The other thing I always try to point out with this table is that there are different groups covered. So state to state, as much as we try to go out and get the broadest coverage for as many people as possible, negotiations happen and amendments are had, and so all of these laws have settled in different ways. So not every group, every insurance group is included, and there are differences in some of the coverage specifics in terms of number of cycles, whether storage is included, things like that.
And so we have to talk about Illinois, obviously. When we went in for this, initially it was really pushed through and started with an OBGYN resident who did this as a summer project. And then as we started to build momentum, we got to get more involvement with Joyce. But honestly, we could not have gotten this done without really two things. One is lobbyists. And I know that sounds dirty, right? Like we all think about lobbyists and we're like instantly like, ugh, right? I was. But they know the who, the what, the when, the how. And that all changes all the time. So we would get a text message that morning to be like, oh, they actually secretly moved the meeting to be now in this building, and we were in Springfield, Illinois. If you've not been there, don't go. But I mean, like, I'm sorry, Barb, but like, you know, we had no idea where we were. We're like driving around all these places, and that's just how it works in politics. It's like a little bit of like who you know and how can you get to them. And you know, the lobbyists could tell us like, okay, now it's going to go to Senate. You have to meet with this person who we never would have known about because he was kind of a secret. And I can only get you into this office at this time. So that was huge to have sort of that insider knowledge. And then we had a patient who was nothing short of amazing. She and her mom and dad drove to Springfield. It's like a 5-hour drive, multiple times. They stayed in hotels down there. They met with every person that they could meet with. And she was so open and honest about being in menopause at the age of 23 because of a bone marrow transplant. What that has meant to her, both reproductive health, her sexual health and functioning. And you could see some of these like, you know, old guys that were like, well, did she just say sex? Oh my God. But what it did was sort of like, you know, sometimes the one guy was like, I kind of see you as like my granddaughter, right? And then it personalized it for him and it let them see these are real people that we are making a really big impact on by having this type of bill in our house.
And I just want to say, if anyone wants to get involved, you have this opportunity, like Kristin's right there with the governor, you know, so there's always that potential upside, right? Some
Sure.
fun.
I got a really cool pen out of it.
So this is a recent coverage, and it differs a little bit. The coverage that was attained in California differs from some of the other states because it was the first state that actually passed fertility preservation coverage where they didn't already have by law coverage for IVF, which of course is what you need, right? And so this was the first, as we term it, standalone coverage. And it's a little bit unique because there's a different structure there to the managed healthcare system, a different regulator who we were able to really closely work with prior to the legislation, and we've been working with now since the legislation passed because there are problems with enforcement and the insurers aren't totally complying. So we've been working with them very closely, but we felt like that was kind of a breakthrough moment to step away from, you know, being linked, you know, to any infertility coverage at all. And this is a recent success, and some people are here in the audience who testified and helped with this. Thank you. So Utah was also a really unique state. This was the first bill that we had that was directed solely at Medicaid in the state. And so it was a little bit surprising, I think, to get that kind of traction. We actually had a different bill that was going to go toward, it was more standard toward the commercial insurers, and unfortunately our author, the legislator who was willing to work with us and was going to sponsor the bill, he lost his race. So all of that work, you know, kind of fell to the wayside, and we switched horses. And this legislator had a personal experience. His son had been a cancer patient, I think, in high school, and was infertile. And so he was open about that, and he sponsored the bill. This is unique in that it is using a mechanism called a Section 1115 waiver. It's a waiver to the state Medicaid plan, and it's in process right now. It's been submitted. It had to be submitted by the end of last year, and CMS at the federal level is reviewing the coverage and hopefully will approve the coverage, and then we can get down to the nitty-gritty of, you know, getting providers enrolled and making sure that this mechanism will work. And I'm optimistic about this because I think it provides a great opportunity, a potential template for moving forward in other states if we can see how this rolls out and if it rolls out effectively. And because of this waiver structure, the Medicaid agency there in Utah, they're required to do a lot of evaluation, so they'll be capturing data that we don't get from the insurers. So I think it'll give us a lot of good information. And I just want to call out that ASCO, the local ASCO group within the state sponsored the lobbyist and was instrumental, and we're still working with them.
And so kind of as we talk about Medicaid coverage and trying to make that equitable, while that was included within the Illinois law, we've had success in getting medications covered for IVF cycles. So if I have a Medicaid patient, I can get all of her medications covered, which is huge, right? I'm not downplaying that because we know those patients don't qualify for things like Heartbeat or Reunite. But what's been interesting is that then when we go back to look through bills, Medicaid actually isn't reimbursing for the procedure costs yet. And it's this whole big long process about being in some special book with all these special codes, and like no one can tell us who does that. We get names and then they're gone. And so the implementation of the Medicaid piece to Illinois' bill has been increasingly difficult. We've got like, Jen Elvicus, if you've met her, is our patient navigator. Her husband's like elementary school friend maybe works in Medicaid, so we're like maybe trying to work that angle, but it's a lot of like who you know and how can you get there. It's been a really interesting process.
Oh, sorry, can I just go back one second?
I mean,
Thread.
Yeah,
Okay.
yeah.
I just want to, so we talked about Utah, and I wanted to also talk about in Washington State, there's been a little bit of a mini breakthrough, I would say, and again, we're optimistic about that, and I know Tyler Ketterall is here from Seattle Children's. They really pursued that and worked with the state agency, and so I think this, the agency there, the Medicaid agency there, basically did an internal review and determined that fertility preservation in this context was an oncologic service and not an infertility service, and that is the basis for their decision to cover it. They are covering it only through the EPSDT program, and they have now a written policy and it's limiting it to OTC. So the next step there is to go back and try to expand that and build on that and get to the underlying rationale, right? Which is that if you have a patient who is able to do egg freezing, they should be able to do that, or sperm banking, or what have you. So hopefully we can build on that coverage. So anyway. In terms of federal coverage, there is not a lot. There was kind of a breakthrough last year. The Office of Personnel Management, we worked with them, and they implemented coverage for all federal employees. It's about 9 million employees. The only caveat there I'm going to say is that the language was such that they said coverage was encouraged, and so our next step now is working with them to identify which policies actually added the coverage. We do know in and around DC, some of the biggest providers, they did do that, but it's not universal within that system yet, so we would like to work on that and identify who's doing it. The Veterans Health Administration has had this coverage for some time, and they are adapting their coverage, and we are expecting that this year they will add ovarian tissue as well to that coverage. And looking ahead, as I said, like pie in the sky, North Star, is to get some kind of federal bill that will go after ERISA, which is for self-insured plans, employers who pay for their own insurance, which is regulated at the federal level. There is a bill called the Access to Infertility and Care Act. It's an IVF and fertility preservation bill, so I don't know really what the prospects are. At least it's a line in the sand that we can discuss. There's also a survivorship bill that is coming out of Debbie Wasserman Schultz's office that we're expecting to see anytime, and we did work on language to include coverage for fertility preservation in that. What will remain or survive, I'm not sure. And we've started to reach out to some people at the Moonshot Initiative, so who are aware of the need for this coverage. I don't think we have time for these.
I know, I don't think so either.
Sorry, I just wanted to point out, so we usually get into, this could be a whole other talk on really the rationales that underpin coverage, whether that's coverage that you're seeking privately or through regulation or through legislation. I think I just want to point out like the top two items. I think one of the most fundamental important arguments to be made is that fertility preservation is medically necessary. And the AMA definition is there, and I think it falls squarely within that. And that is how, if you go to the next one. So some examples we've seen where appeals were brought, these were specifically done in California. That's on I don't know how you're looking at it, the left or right-hand side of your screen, but whenever we've gotten to external review, the insurer's decisions to deny coverage has been overturned. And these decisions preceded the passage of the law there. So that was independent of any legislation. So I think that's an important, gatekeeper to establish the medical necessity of these services in order to get coverage. And I think, of course, and we've talked about this, it's been touched upon before, but I think not all of them, but most of the bills actually reference ASCO and ASRM guidelines on fertility preservation, and I think it's been really powerful to share that information with legislators. Like, all of the relevant medical societies have recognized that this is part of treatment and that these offerings, these interventions are considered standard. So I think that's something to have, if you're going in for discussions with people.
And I think what's important about that is, like in Illinois, when we did that, they didn't specifically list out, oh, it's just egg freezing and embryo freezing. They listed what the guidelines were. And so then when OTC was non-experimental through ASRM, that just got included. We didn't have to go back and amend the bill, which is like a crazy pain.
Yeah. I don't know if
Yeah, I think we're gonna kind of skip through these. We're definitely happy to talk through them, but these are kind of some of our top, when you really think about relative costs to what it's going to be for these, per month per member, we're really talking about pennies. And when you go to meet with your legislators, these are the types of things that they'll want to know.
And I think there are so many ethical arguments that we can get into about iatrogenic infertility generally, the irreversibility of the harm, the disparate impact that this has on women and obviously those of lower socioeconomic status. And then really what we're talking about is someone potentially being sterilized, right? So it's really like a basic human right. So I think these are your sharpest arguments. In terms of the nuts and bolts of advocacy, usually identify and go through all the barriers, and there are many, and it's complex, but we do want to say that teamwork makes the dream work, and as I said, many of you in this room have been involved with this work, and we appreciate that support. I want to point out, so some of those logos you see, that was the whole team in Utah. It took many organizations, institutions, the Huntsman, Doug Fair's here, testified. It takes people being willing to have those phone calls, have those meetings, come to hearings at a moment's notice, and testify and bring patients. So I'm getting the hook. But we would love to answer any questions that you have about how this is working, how it's not working, how to move it forward, whatever we can do to try to facilitate that process.
And this was one of the patients in California who, very beautifully was able to summarize the need for fertility preservation, and had to go through the whole denial process and writing the appeals. But she did such a great job, right? Of
she's my poster child in California right now because she actually was diagnosed right after the bill was passed. So the law was in place, and she was still denied coverage, and we fought through and got her the coverage that she was entitled to, and she was able to preserve, and now she's in a position where she wants to look to start building her family, and there's no IVF coverage by law in California, so that's something that we're working on as well for survivorship.
Joyce, I had a question. So
Sure.
I've sat through a couple of the meetings with you of trying to get these things going. And one of the things you often will say is you need to go to your employers, these large institutions, and they need to have coverage. And a lot of them do, but I would say some of it's very subpar, and it's very, split where, they'll have $2,500 total for IVF and meds or fertility and meds. Maybe it's fertility preservation is excluded. So when you're going to some of your employers or kind of the larger employers in your state, do you have guidelines of what should be asked for?
Well, as I said, we have a model, bill language, and with that we kind of don't publish out really that much, our principles of coverage, so I can get you that document. That explains more why we think each of these things is important, so we don't like to share that out with the insurers as much as we can avoid it until we have to. I would say also that, there was a new Mercer survey that came out of employers that have IVF coverage, comprehensive fertility coverage, and they really showed very little impact financially, so I think that's helpful. Unfortunately, the insurers don't share, data, and so it's very proprietary, and it's hard to get at what actual utilization is, for any of these services. We do now, as more and more states come online, many of them do require a fiscal analysis, and some are more comprehensive than others. So with regard to fertility preservation, we do have several studies now, and as Kristin said, it's pennies per member per month. And so we do try to go in with that argument as well, like this is what insurance is for, right? So we're trying to spread the risk over a whole pool, and while it's prohibitively expensive to an individual, perhaps, to have coverage, over the whole pool, it's not. Tony?
I was encouraged by these two women at lunch to come up and comment. I am from one of the yellow states, unfortunately, where we don't have coverage. And I'm sure there are some other people in the room here who have to deal with that. It doesn't sound like it's totally a dream in a green state either. You have to continue to advocate. But I was discouraged when hired into my role. How can I build an OTC, TTC program without coverage? And thanks to your study's generosity to cover some costs, it can help with the families and the conversation. But what I was going to say is that, I called around to 19 hospitals, most of you were in the room, and you were all so gracious sharing data with me about, percentage covered when you didn't have insurance coverage, how you bundled. This room is one big team trying to solve this problem, and we move forward with OTC and TTC. We've done about 10 cases, and 9 out of 10 have been covered by insurance when bundled. 1 is in appeals, and that's Medicaid and commercial insurance. The discussion at lunch was, do you tell people, or do you just keep doing it and not tell anyone?
I'm a big fan of do not look a gift horse in the mouth.
What?
Joyce said write it up.
I love to share that example out, right? So it might be beneficial to share with others, but yes, we wouldn't want you to lose that. I do think some of the insurers, right, are covering these surgeries because they're coded as cancer, and then they don't really know. It's not really being maybe laid out, and if they had a better understanding of what was happening, they might not cover it. So I think that's the rub.
We did such a good job, there's no questions, right? Awesome.
Thank you.
Thank you, guys.